Dr. Chu. It is great to have you here.
Hi, Diana. It's nice to be here.
So, full disclosure, you and Dr. Sechkin are my doctors. I've been under your care for several years. Um, I have been in the situation as a patient sitting across from you, trying to explain my endo symptoms as best as possible. But as anyone in this community knows, it can be really daunting. Even if you're comfortable with your doctor, it can just feel intimidating, a little bit of like, am I oversharing? Am I undersharing? What information is really pertinent and helpful for you as the doctor in order to help your patient get even, let's just say, an initial diagnosis?
Yeah, that's a great question. I think a lot of patients, right, when they come to us, can be intimidated. I always tell patients we're probably not the first doctor you've seen, right? So unfortunately, we may be the fifth or the 10th, maybe the 20th. Unfortunately, we do have a certain set amount of time, and patients may come in with quite a few records, quite a few questions. And so I always say prepare as best you can, right? So if there are treatments that you've undergone, surgeries that you've undergone, imaging, labs, try to collect those to the best of your ability and present them to us so that we're able to go through them and really, really dedicate most of the time to talking about, those findings, being able to do our own exam. And so we're not focusing so much on, looking up, hey, what hormone have you been on? How long were you on it for? What side effects did you have? If you have that information already there, we can take that information and make it, just a much more fruitful conversation. Another thing I often recommend to patients is, bring a support person. I
Mhm.
think that's really important. Sometimes when we talk, I think there are studies out there that say you only absorb maybe 50% of what we say. Um, and so having that backup there to remind you to ask the questions that you had prepared, to listen, to take away and to discuss, I think that's also a pretty important component. And I think the last one is just to, let us know if you're comfortable. The first meeting, we may not get through everything. We may not, you may not be comfortable with us yet to have an exam, and that's okay. I really think that is part of building a good patient relationship, and just to let us know how you feel.
What symptoms do you want to know about? Or is there like a top three? Because is there something, in terms of oversharing, overdoing it? Like, what is good information, important information for you to know? And then what is like, I don't need to know what you eat for breakfast, like that kind of thing.
I mean, I think the most, we always talk about what's like a chief complaint, right, in medicine. So I would say what we always want to know, hey, what's driving this conversation, right? Is it, yeah, I have some gut issues, but I've always had gut issues and I'm not so bothered by that. But if this is the reason that you're here because you've been to the gastroenterologist, you've gotten a colonoscopy, endoscopy, you can't wear any of your pants, it hurts, you're nauseous, you are losing weight, then then the gut is the primary issue here, right? So we're going to focus a lot of time talking about that. For other patients with endometriosis, it's not going to be that. It might be, symptoms of, painful intimacy. And, we've had a lot of therapy for that. We've gone to the pelvic floor therapist. We've tried, this suppository, that suppository. We've gotten, Botox into the floor, right? So I think kind of knowing kind of that first chief complaint, is really important, and then to gather some of the other information. I always tell people to, you know maybe the first time we meet, I ask questions, and they're like, you know what, I'm not sure. Let me think about that, and I'm going to track that. And so often patients will come back in their second visit and be like, you know what, I was thinking about what you said, and actually I do notice there's a pattern. I do notice that during, I think it's my ovulation, that's when that tends to occur, right? Symptoms that occur in a cyclic way are also very important to us, to know. And obviously if they occur in a non-cyclic way, right? So that gives us always a bit of information. Um, yeah.
How do you, at what point when you meet with a patient, 1, 2 times, 3 times, whatever the times are that you figure out, okay, it's time for surgery. I realize that's very individualistic because it depends upon the case and the severity of the symptoms and what kind of comorbidities could be presenting, whether it could be bowel obstruction, lung collapse, those are emergency cases. Um, how do you evaluate when someone needs to have a surgery and perhaps when someone could avoid going in?
Okay. You already said the things that would definitively require surgery, right? Lung collapse, bowel obstruction. So that's when your bowel is, twisting off, twisting closed, right? So those are surgical emergencies, but they actually in endometriosis don't happen that often, right? This disease is slow, it's insidious. The symptoms come on. Sometimes they, maybe they go into remission for a while. Say a woman gets pregnant, which can happen. So I always tell patients, a lot of this is clinically driven, okay? Meaning that depends on you, right? I know there are patients walking around with what we call asymptomatic endometriosis, clinically silent. So obviously they don't need surgery, right? So if they're feeling okay, they have no symptoms. Um, and we really kind of divide endometriosis in these two kind of larger buckets. We stage endometriosis similar, in many ways similar to cancer, even though it's a benign condition. So the most common staging system we use, um, we put endometriosis into this like early stage, late stage disease, right? Early stage is this stage 1, 2 endometriosis, and it really can't be visualized on imaging well right now. So it is still a clinical diagnosis. Does that disease have to be operated on if you don't have symptoms? A lot of don't think anyone would necessarily do that. You can't see it, and you don't have symptoms.
Yeah.
Um, but for a lot of those patients, they present with very severe symptoms, right? Symptoms that are impacting their life. They're causing them to, skip school, skip work. And when it gets to the point where it is, I would say, taking up a big portion of your life trying to manage, that's more than a reason to evaluate this.
Mhm.
Most women have tried some form of birth control, or at least been offered it.
Yeah.
And that's completely reasonable as first line. I would say that has far less risk than surgery. It takes far less time and investment. But there are some women that don't want to try that, right? And that has to be respected too. So I think, again, yeah, it's tough because it's individualized. But the idea is that if you have clinically relevant symptoms,
Mhm.
right, that suggest a diagnosis of endometriosis, it's impacting your life, and this is something you want to pursue. No one should, tell you that that's not something you can do. And then if it shows up later on in those more advanced stages, then that at least needs monitoring. Okay. If surgery isn't something you want to pursue. But I would say when you're seeing what's called, deep endometriosis, maybe endometriosis impacting an ovary, you really have to understand what it means to not have surgery on that. And if that's, what you want to do, then that can be I always say shared decision making. Be
Right, right. And the impact of not having surgery if and let's say there's an endometrioma, chocolate cyst present.
Mhm.
Obviously, if there's like ovarian torsion or intermittent torsion, that's an emergency situation, I would assume.
Right.
Um, but with the endometrioma, that fallout is fertility, correct?
Fertility, hormonal status. If, unfortunately, sometimes they leak. So it is possible that, women get infected
Oof.
from them. That
Yeah.
is more rare and that has to be addressed. So there are things that we do monitor. We do know actually, if, as we've sort of long suspected, there is a link between actually ovarian cancer as well. Um, and it does seem to be a bit higher in these endometrioma patients. So I think counseling is really important. Okay, I think monitoring to the best of our ability now is what we know. So
Yeah. So the indication of pain is not necessarily, even if you think, okay, I can live with this, the pain isn't that bad, but you might have other things going on that you can see through, sonogram and MRI, like an endometrioma, like you said, shared decision making. What's the best outcome and decision for the patient, long term and short term.
right. I mean, pain is such an interesting concept, right? Because pain is subjective, and pain is only what you describe to another provider. So in many ways, what at what point does a person also then decide, like, I personally have had enough of this?
Mhm.
Right. I would say that most people do not want to have surgery. um, and so I've had people come and then come back a year or two later, right? They weren't ready at that moment. And it's very hard to say when somebody is going to, say enough. And that
Mhm.
probably applies to a lot of other things in
Right.
lives.
Mhm.
But I think that's something that I have always found very interesting with this disease. Um,
And with endometriosis, it's progressive. It doesn't. I mean, I guess there's such thing as endometriosis can burn out or flame out or not, develop into bothersome adhesions or having issues in the abdomen and extra pelvic areas. But for the most part, is it a progressive disease?
Yeah, I mean, for the most part, that's what we say, right?
Yeah.
And I think that holds true for a lot of women. I don't feel like a lot of women, have these terrible symptoms and then miraculously get better with no treatment.
Right.
They may get better with treatments that aren't surgery, right? That could be whether it's hormonal or diet mediated or exercise, or they've tried other, integrative treatments. But I do think it is a disease that likely needs treatment, right? I also think it presents very differently. So I always tell women that I could put a camera in 10 women that are at the age of 30, So maybe they've all been on hormones for 5 years, let's say. Um, we're going to find 10 different pelvises and we'll probably find 10 different clinical presentations, right? So the way that your endometriosis progresses, the way that it presents is unfortunately going to be different from the patient next to you, which makes, reading certain things very challenging because it does have to be individualized.
Huh. And endometriosis adhesions, scar tissue, that can impact organ function, correct? Like there could be, um, issues that happen with the ureters that could result in, and again, this is rare, not to scare anyone, silent kidney failure. Um, when how do you go high alert? Like you're sitting there with your patient and they're telling you symptoms and you're thinking, this could really be more serious than something else. Like this could actually be a ureter strangulation from endo. This could, like, what gives you the alarm?
Right. There are certain symptoms that are particularly worrisome. So, cyclic hematuria. So if you're, voiding and you're having blood in your urine, that's not typical. If you have very specific, um, for that you may initially have had some flank pain or some other pain that isn't as typical with endometriosis. Most of the time, too, depending on symptoms, we do get extra imaging. So we rely a lot on our radiologist. I always say endometriosis is a team sport. Okay. And so you have to know people that can help you in each area because, as you know, as a surgeon, you may sail part of the ship, but I really think this is a community, right? So if you have a radiologist that has never seen endometriosis, they'll never report endometriosis on a scan. They won't know to look at the ureter. So even our own radiologist, I called him yesterday to have him help me look at a case. There have been a rare couple of instances where they, as a team, missed something. So we actually took those cases back to them so we could review them together, right? So it's this constant process of learning and growing together with your team, making sure that they that if it ever happens, we don't have this type of clinical situation again. But they're very good at looking for those types of emergencies, right?
Mhm.
For the hydronephrosis that you would see, which means a dilated ureter, for some sort of transition point or some sort of mass entering the rectum. Those are the things that are sort of key to take note of.
Mhm. And those are the situations that would require surgical intervention.
Yeah, absolutely.
Right. So, yeah, I mean, I think as a patient, it's you know your body, and I think you know when there's something acutely wrong, and you need to address it, but also to realize that I know we always say endometriosis surgery is optional, right? It's elective, uh,
Yeah.
but to an extent, right?
Yeah.
That like language can be a little tricky because it's I've spoken to other patients and I'm sure you've heard them too. They're like, "Well, I didn't want this surgery. This was not what I wanted and I needed it." So, how is that framing? Like how is that something to reframe that it isn't
Yeah. It's a
it,
little offensive actually to
right.
women, and I don't mean to say it like that. I mean to say that you have a choice about what you wanna do to
Yes.
your body. Um, I would say in many ways it's not elective because it's you're not able to work, you're not able to function, right? And so, you know, and I say this other thing and I don't mean to be taken poorly. I just mean, it's it's worse than cancer in a way. And I say that only because when you have cancer, it's taken very, very seriously, right? I have cancer, it must be treated. This is the path to treatment. When you say endometriosis, they're like, oh, sure. So, you have painful periods or what is that? And so I don't think it's really, in a lot of different communities, addressed in the same way or addressed with any sort of urgency. And so, yeah, we need to maybe reframe how we say that.
Right. Just for just discussion purposes and also then from even insurance purposes as well. But
Correct.
it's a complicated disease because there is such limited understanding outside of the community itself. I think that I've been to OBGYNs and they really say they know what endometriosis is, and then when you get into it, they have no idea the severity of the disease. So I think that's tricky for patients too. If a patient is getting stonewalled by a doctor and the appointment is going nowhere, I'm not talking about someone with like you who's compassionate and understanding and really knows their stuff with endo, but let's say they are in a meeting with a doctor and they just feel like they're getting dismissed, they're getting gaslit. How does a patient navigate that um respectfully? Can they just say, okay, we're not seeing eye to eye and walk out?
I think you can. I think it's a relationship. And I say, there are other endometriosis providers out there. We're not necessarily saying, we are the only people out there, right? I think you build a relationship similarly to someone you see regularly, a therapist, a pelvic floor therapist. Um, you have to feel comfortable. And I think trust is the most important thing you can have with a patient, especially after potentially some negative experiences they've had. And once you've lost trust, you've sort of lost the foundation for this relationship. And how are you going to trust them to, uh, you know, take you to sleep or do something for you where you may be at your most vulnerable? So if you feel like that can't be maintained or salvaged, I think it's then time to find a new provider. You just want to feel heard. And I always tell patients it's not like we've never had issues from surgery. If you are one of our patients, we do these surgeries, they come with risk. It can be scary. And you just have to know that we're gonna be there with you throughout that, right? Otherwise, and I think that's an almost bigger part of the surgery in and of itself, right? For the surgery, you're asleep. So,
Yeah, it's the
yes.
after bit. And there are surgeons who, you know, be like, I did the surgery and then which is fine. They can push you to not push you, but recommend you go to someone else for your aftercare and have different doctors, like you said, an interdisciplinary approach.
Yeah.
Um, but it is important that you have implicit trust with your provider and that you feel comfortable and that you can talk about really all of these things because we know that endometriosis affects all aspects of life, whether it's career, work, kids, like family dynamics, relationships, school. Um, so to be able to have someone that you can trust with your body and even your mental state.
Yeah, I mean, I think that's important, and, you know, I think through surgery and through some of our questioning, we get, you almost can't help it feeling, more connected to patients because you hear about their story and maybe it's a fertility story.
Mhm.
Um, and, we're not, we're not robots, right? So we do happen to care. And so it's one of those things where, um, it just has to be something that is, positive, right? So, I think that's important to say is just if you have a provider that you don't feel like is on your team, that's okay. There are a lot of providers out there and you just find one that you feel like is.
This is going to be a hard thing to do, but if possible, can you encapsulate one nugget of wisdom or advice you could give to an endometriosis patient right now who might feel unheard and unsure how to go forward in their endo journey?
Mm. Well, obviously the easy one would be to say advocate for yourself, but how do you advocate for yourself? I think is really the harder thing to do. And what what I would say is this: it's probably if you're starting your journey, you feel isolated and alone. Um, and I think that holds true even for patients, say in New York City, one of the biggest cities, in the US. So I think to also find a community out there, to find your support system. And that may not come from your direct friends or family that aren't sharing your experiences, but I think that that can be very powerful in helping you, um, direct some of your energy, understand the landscape out there, help you seek the right type of provider.
Mhm.
No one is more resilient than an endometriosis patient looking for answers. So I and they're more common than you think, right? So you just have to start asking around, and I think people would be surprised uh, to find out who's even within their circle that might share their experience. So that'd be my advice in the beginning.
Well, thank you so much for your time, Dr. Chu. It's always lovely speaking with you and having you explain a little bit more about endo and also just how patients can continue to help themselves in the process.